Hey everyone, Dr. Smith, MD3 here. Today I am very excited to introduce our special guest speaker, Dr. Kunal Vakharia. Dr. Vakharia has been with Tampa General Hospital as an associate professor of neurosurgery since August of 2021. Dr. Vakharia completed his neurosurgical residency at the University of Buffalo, followed by fellowships in both cerebral vascular and skull-based surgery. In addition, he holds Masters of Business Administration and Bioethics. Today, he will be doing a deep dive into stroke interventions and new technologies that we may see on the horizon. Thank you again for taking time out of your day, Dr. Vakharia.
Yes, sir. Well, thank you so much for coming in today, Dr. Vakharia. We really appreciate you taking time out of your very busy schedule. So without further ado, I'd like to turn it over for you for your information.
Thanks, Andrew. So I kind of wanted to talk a little bit about the whole process of how stroke code works, where we're going with stroke, where stroke research is going from here, and what the future of stroke holds for us. So what can coordinated stroke care look like, and a couple looks at what ischemic and hemorrhagic stroke interventions we have. Disclosures, basically colored by where I trained and where I work. And this is what I'm going to kind of walk us through. So what can EMS do at the scene? What happens when a stroke code is called? What interventions can we do? And where do I see the future of stroke going? So stroke is a pretty important topic, and it continues to grow every year, and this is already several years old. So nearly 800,000 strokes a year are suffered by Americans, so a growing problem across the board, not only in America, but across the world. Stroke is starting to match ischemic disease throughout, including cardiac disease, both from the WHO and CDC reports. So the real challenge here is how to find a way to get these patients to care, because it's an acute issue that we can help take care of. Just like we did for coronary ischemic emergencies, same situation happens here. The biggest thing is evaluating a patient first and foremost. And this is obviously the gold standard that we use when we evaluate a patient in the ER. Our neurology team descends on the patient and does what we call an NIH stroke scale. The two things that they get are time of onset and what the exam is. And to make that standardized so that all of us can communicate quickly and efficiently with one word or one number, they have this algorithm that kind of walks us through the different things we look at to determine whether or not a big, impactful, long-term stroke is happening. And so you can see part of this is about consciousness, part of it is about speech, part of it is about motor activity. But this is not necessarily the easiest thing to do in the field. So there are a lot of other options that you have in the field to look at the severity of stroke. Florida, along with a couple other states throughout the country, but Florida in general has done a really good job campaigning to bring stroke care across multiple different institutions, hospital systems, and areas. And because of that, there are a lot of different systems in place and protocols in place. Finding a way to standardize that and or finding a way to at least be able to communicate to the ER whenever you have a patient en route is kind of the gold standard, and what we're trying to figure out and make more standardized across EMS protocols. Now, stroke can be one of many different types, and here you can see most strokes are ischemic, meaning a blockage in the artery, and a certain percentage are about hemorrhagic, being either a ruptured aneurysm, AVM, or intracranial hemorrhage, which we'll look at a little bit more. Distinguishing between these is not necessarily part of the initial evaluation, although it is important for what we do in the initial evaluation in the ER. It's not something we have the capability to do just yet in the field. In the field, what we really need is a quick and dirty assessment of function. So these are a couple of the different scales. So you have the Los Angeles Motor Scale, the FAST ED scale, the Cincinnati Pre-Hospital Stroke Scale. Each one of these does a couple things. The whole paradigm and shift and advertising campaign that stroke had, looking at face, weakness, speech, has really played a big role in determining whether or not we think that's even something that's on the board. So when an EMS provider sees a patient and has any suspicion that a stroke's happening, they go through whichever one of these they feel most comfortable with, but something that they can at least communicate efficiently and effectively to any other providers or to ERs. So you want to look at weakness, face, and speech. Really, those are the three big things, and you can see that across each one of these. The best factor after that is to know when it started and have a contact number for family. With those three pieces of information, we have so much that we can get going in the ER and start the stroke protocol that makes everything run a lot more smoothly for that patient. Again, the NIH stroke scale, you can see the level of complexity is significantly higher when we talk about the stroke scale in general. Something I see in the future for EMS providers that's not necessarily standardized throughout. So there are, on the right side, you see a mobile stroke unit, essentially a CT scanner in ambulance. Yeah, it's cool. It's not the best quality image, but it does give us information like, is there an obvious stroke? Is there a big hemorrhage? Things like that. It's been employed in a couple areas and people have written about it and showed how effective it is in Houston. But in general, I don't think this is necessarily the way of the future. It really limits and ties EMS's hands and capabilities from that standpoint. But there are things that are coming out, like on the left-hand side, a helmet that looks at blood flow or does some sort of ultrasonic evaluation or ultrasound evaluation of the head to determine, is this a hemorrhage or is this a stroke, ischemic? Those kinds of delineations dramatically change how we encounter a patient in the ER. We've gone to starting to take patients with stroke symptoms that have a negative CT, not getting the CTA and going straight to the angio suite. We've started actually building an angio suite in the CAT scanner to eliminate the time of transport from CAT scan to the angio suite. So really, when we talk about eliminating time, it's all about making the diagnosis. That's where a majority of the pre-stroke thrombectomy time occurs. And so these are a couple of the things that people are working on and may come out in the future. But that's how EMS can really help the ER get started and get on the right pathway early. This is essentially the paradigm that we walk through. This is what happens when a stroke code is called. And there are a couple nuances throughout this. So EMS sees a patient, thinks it's a stroke, and they call an ER. Here's a picture of Tampa General's ER, obviously. After the Tampa General gets an evaluation, there's a couple different ways this can happen. There's actually a tracking app that some hospitals use that show the ambulance en route, so that we can actually time it minute by minute so we have the entire team on hand. But more importantly, the biggest thing is the minute you hit the ER door, 2 people descend on that patient, a neurology team and an ER team. The ER team does the initial evaluation, makes sure we have the ABCs, airways, breathing, circulation set, and gets the patient off to neurology. And during that transition to get to the CAT scan, neurology does the full and thorough NIH stroke scale. At that point, we've determined whether or not we have a high or low level of suspicion. We start calling in the team from home to get to the IR suite for intervention. After you get from the hospital stage, you're in the ER, you get a 3D picture. This helps in localization of if there is a stroke and looking at the vessels. And there's a couple different aspects that happen after that. If there's no blood on the scan, the patient starts getting TPA. And then after that happens, they also get something called a CT perfusion. And you can actually see that image on that lower left-hand corner. That's an image that gets pushed over straight to our cell phones. I see every single scan that comes through the hospital, and I know immediately, is this something I need to intervene on? How many people do I need to get involved? Who do I need to call? And what do I need to employ? I know exactly what I'm going to use to get to where I need to go, and this happens within minutes from when the scan's done. We have TPA hanging on the way while the patient's being rolled upstairs to the IR suite. And that bottom middle image is the IR suite as we work on pulling out a clot or coiling an aneurysm or whatever it may be. And eventually after that, the ICU has already been notified when stroke codes are called. So they have a bed ready to go and have all the parameters set. So communication's already happening while the patient's coming through the ER and through that process to get everything set up in the ICU. And so there's a lot of different parts that happen all at once with the stroke code. But the biggest thing and the biggest time lag ends up happening in that early initial setting from getting to the ER to the diagnostic stage. And cutting down that time is dramatic and impacts patients dramatically. This is just another picture showing you the different systems we have that kind of help with expediting patients from diagnosis to the intervention suite. So that same thing that comes up on my phone is a new system that we don't wait for radiology. There's actually an AI system involved with it that helps us diagnose, hey, we think there's a stroke here, and really focuses both the neurology and neurointerventional team's attention on it. So when we see an ischemic stroke, really the nuts and bolts of this are, what can we do to get that clot out? How do we restore blood flow? So we either put a stent up and pull the clot out, or we try to suck it out. So that's the nuts and bolts of this. There's a couple different ways we do this. Either we do it with just the stent, with a combination of both, or just aspirating by itself. But in the grand scheme of things, it's a relatively straightforward procedure. here's a couple examples. So this is actually an 88-year-old guy who came in aphasic. You can see in the middle of this, it says that he had an NIH stroke scale of 18, which is pretty significant. Anything above 6 at this point is something we usually consider intervening on, because we know that long-term it dramatically impacts their long-term outcome and their what we call modified Rankin, but really their ability to live on their own and have some sort of independent quality of life. His initial image and all of that stuff that came across shows a left M1 occlusion, which I don't know if you can see my mouse, but you can see on the left side of his head, there's a big red sphere. And on his 3D reconstruction, you can see there's a blood clot sitting right there. That's a blocked off vessel. And so we get him to the angio suite and we get access. And here we got access in the arm, and you can see the tube, and this is us working in real time. He's got really, really, really tortuous and windy vessels. In that middle bottom image, you can see we are able to guide a wire under radiographic imaging all the way up into the neck, and we get our proximal access catheter into the neck, and you can see just how many turns we have to navigate through with that wire. So it's quite challenging sometimes. A lot of our technology has improved so that you can see we're just pulling that catheter all the way up into the carotid on that first try without even having to take a picture. So all of this is done blind just to move as quickly as we can. That's a picture of the initial angiographic image showing the M1 occlusion. And I think I highlight it here and I circle it for you there to really show you exactly where that M1 occlusion is. So that's where he's getting no blood supply to that half of his head. So after that, we work on getting our tube all the way up around all of these turns. So this is a combination of 3 different catheters. It's one tube inside of another, inside of a third, with a wire inside of that. And we get all of this up relatively rapidly across all of these turns into the head. We use a lot of the bony landmarks to get to where we need to go. A lot of times we do this with the patient intubated. In this situation, we didn't want to waste the time to intubate the patient. So you can see he's breathing and moving, and he turns his head every now and again. So all of our imaging is a little bit blurry because of that, but we know all of our landmarks based on anatomy and based on the bony landmarks on the skull. So we're able to really navigate this tube up partially blindly, but knowing our basic landmarks to get to the basic area where we need to go so we can try to open up this clot as fast as possible. And this is real time. So you're seeing us actively push the tubing up, get all the aspiration tubing set to be able to put a stent retriever across this and try to pull this clot out. And you can see the patient moves their head as this happens. So that's sometimes part of the challenge, but I think in certain situations, it does better for the patient in the long term to move as fast as we can. So here we get our wire across, and you can see it going across the orbit on the middle upper image. The wire crosses the lesion right here, and that's how we see that we have enough access across this lesion to bring all of our other material up and safely do a thrombectomy and pull the clot out. For the sake of time, I'll move a little bit faster here, but we have the microcatheter past the clot now. And so we get the wire out, and under a magnified view, you can see we're past the clot and you have good flow. But what you also see is that the blood is not washing out. That contrast is staying there because the clot's keeping all that blood static. And so we deploy a stent retriever here, and it's a little hard to see just because of how far away it is, but what you can see is a little marker right inside of the left orbit. And that marker is right where the clot stent retriever that we talk about is. And then we pull our aspiration catheter right on top of that. We usually open this up so that the brain has some room to breathe. The minute that stent retriever opens up, it pushes the clot out of the way. And then that's us pulling the clot out. And this is the final run. And now you can see all of those vessels are filling. And the benefit of also not intubating these patients, particularly the elderly patients, is this guy started talking on the table. He went from aphasic and not moving his right side to talking and able to communicate with us very effectively. So you see a lot of benefit immediately, and you know you've done the right thing. Another example is another 61-year-old gentleman who the challenge with part of our grading scale is we don't always know where the clot is. So he had right-sided weakness. He was altered. He wasn't really making sense. We didn't know what was going on. If we look at the stroke scale, he's a 28. That's an incredibly high number and debilitating in any way. But what they found is the main artery to his brainstem was clotted off. And you can see on that middle image that we call the time to peak, the entire back and brainstem is dark and not getting blood. So we don't wait usually for this image. We have to get a couple, but in this situation, we rushed him to the angio suite. So again, we got a big tube in. This one we went through the groin and we got our tube all the way up into the neck. You can see us climbing the vertebrae. He is intubated because he's not really able to stay still for us. And you can see we get our entire system up across this. And we're able to, in this situation, use a couple devices that allow us to suck this clot out. And you can see on this bottom image under the negative, you can see all of our devices slowly making their way up. And this final image, if you look right in the middle here, you can see the catheter is right here in an air cell that is showing you that the catheter has gone through the clot and is just sitting there aspirating on this clot. And our system is hooked up. And if you look to the left-hand side, you can actually see what we're doing. This is the tubing that is actively suctioning out blood and putting it in a pump. So the fact that we don't see blood actively coming out until just now means that the clot actively got sucked in and now we're getting blood. So we stop the pump, we take it off of our catheter, we do an injection, and we show you have great blood flow throughout and you've restored blood flow to the brainstem. So that's the final picture, and you can see it's dramatically different. His entire brainstem's now getting perfused.
Wow.
And that's the clot we ended up getting out of the canister. So, yeah, I mean, this patient essentially went from being completely incoherent and not moving to awake and talking and alert. So there's a lot of benefit we can do by moving quickly, and particularly in these critical regions. Andrew, I'll pause for a second if you have other questions, but I did want to show some examples of ischemic or hemorrhagic stroke as well.
Yes, definitely. And I'd just like to take a moment to reiterate what you said for the men and women of our system. One thing we see a lot is they come in with the last known normal time. And sometimes we really need to differentiate with family or the connections that they might have been changing throughout the day. When was the last time they were truly normal? So maybe not a sudden change. So when you're getting a last known normal, really hammer down when was normal versus was there a slow change or a rapid change. That is critical. And that often changes when somebody arrives to the ER. And again, getting a great contact number where we can get that information should it not be available is critical. So thank you for mentioning that. And I definitely love to see some of the hemorrhagic information.
Yeah. And part of that, and I guess it also helps with ischemic stroke too, but when I show you the hemorrhagic cases, knowing if patients are on blood thinners helps out. And it's just one of the easy items we can get on the checklist. So like you said, quick exam, last known normal from the family, a contact number, blood thinners.
Yep.
Those are the keys.
Exactly.
So like I said, stroke cares a couple different things, including intracranial hemorrhage. It's a patient who came in and you can see pre-op, he's got this hemorrhage in his basal ganglia. Post-op, we ended up going in and taking this out. And this is not always done. We actually have a trial going on for this. But in large ICH, we end up evacuating. But in these smaller ones, if we can navigate, we get these special images urgently to show all the maps of the motor fibers and everything that could potentially be traversed. You can see our target as we get into this clot. And we have a minimally invasive endoscope that actually goes into the clot. And you can see the views from the beginning to the end and the actual clot that comes out in someone's hand on the right-hand side. So that's what we're doing now, and it's kind of the wave of the future and something that's picking up a lot of momentum, and we have a couple trials going on for it. So that's what we call intracranial hemorrhage or hemorrhagic stroke. Part of that is also subarachnoid hemorrhage with AVMs and aneurysms, but one of the more common things is aneurysms. And we have a lot of different systems that we're working on now. This is part of our current research looking at whether or not we can determine which aneurysms will rupture if we know about them in advance. And these are all the different endovascular techniques we have. And this is only probably 5% of what we can do. There are so many different coiling adjuncts, devices, webs, pulse writers, stents that we can do that dramatically change these aneurysms and the flow dynamics in these patients. But this is just one example, which I think, again, illustrates that there are a lot of different ways to do things. This is a 67-year-old lady who came in with a ruptured ACOM, and you can see all that white in the ventricles, meaning in the middle of the brain. So on this middle image, that's right here. And all of this white that you see here is all blood. And it's not in the brain tissue like our last patient, but it's in all of the valleys of the brain. And so this is what we call subarachnoid hemorrhage. And in this picture, this is another video, but in this angiographic picture, if you look, this is a carotid going up, and here is the aneurysm. It's a pretty sizable aneurysm that bled. And so what we'll show you is that we're able to actually pull the same thing. It's a combination of a couple different catheters going in a stacked manner, but we're able to get this catheter up a very tortuous artery in the neck. And we do one tube inside of another to give us that support. And here you can see under negative roadmap, we actually get a very thick tube inside that aneurysm. And this is actually the device coming out. And you'll see in a second that it's a pretty stiff device initially, but as we deploy it, it softens dramatically. So even in a ruptured aneurysm, we're able to deploy this with such precision. And here it opens up slightly at the very end and it becomes soft to allow us to manipulate it into the aneurysm and actually block flow into the aneurysm relatively quickly. And so now it's deployed. It's kind of like a web, a big mesh balloon. And you can already see there's stasis of contrast in the aneurysm, which means that if we get this out and everything else looks good, within a couple months, that should actually heal beautifully. But the risk of that bleeding right now has dramatically decreased. And so those are the kinds of things we do in the acute setting to make sure that these patients don't have rebleeds, particularly in that first 24 hours. That's hemorrhagic stroke. I have a lot more examples, but I think I for the sake of time, I'll cut that short. But I do kind of want to talk a little bit about the future of stroke if you have a minute.
Yes, definitely. No, this is fascinating. I'm really enjoying this and learning a lot. So please go ahead.
Great. Looking at stroke trials, since stroke and thrombectomy has been such a big part of our lives, in the last 5 to 7 years, really, we have started coming out with 1,000 different trials, really proving where we should be doing things and where we shouldn't. And you can actually see, I think if this plays, these are all the stroke trials that we have to learn about just to make sure we know what we're doing and talking about. So this goes on for a while.
Right.
But the point being, at the end of the day, there's so much going on and so much continuing to go on that there's so many changes that happen constantly. I think we have 20 plus trials running looking at stroke and different interventions. So there's always new things coming out in the field. Big events that have happened in the recent past. We don't necessarily only treat patients within that first 4 to 8 hour window. We have a new trial that came out, DAWN trial, which basically looks at patients based on perfusion, and even patients up to 24 hours out that have salvageable brain can still undergo thrombectomy because we have a chance of saving a significant portion of brain. And those patients do dramatically better. So that's a big and probably relatively pivotal trial in the New England Journal of Medicine. The biggest thing here is we proved that the number needed to treat was just around 3. Meaning if we treated 3 patients outside of the normal stroke window, we saved a patient. And that's a pretty traumatic number because when we look at any of the other fields like cardiac for cardiac intervention for MI, that number is at least 1 in 8 up to 1 in 40 for carotids.
Yeah, and I was even just thinking, like, for reference for some of the men and women of our system, the number needed to treat for aspirin in a heart attack to save a life is like 80. So only 1 in 80 people is going to be benefited by an aspirin. How important is that in a heart attack? So this is incredible having a NNT of less than 3.
It's a pretty significant number, and I think it's changed our field quite a bit. The other thing is we used to only pull out clots from big vessels, and our technology has dramatically changed. We've pulled that target out to M2, M3, and there's a new trial looking at going even further. Biggest challenge in this situation is, we want to be safe when we do this, and we want to be able to save big, highly relevant, eloquent brain. And again, like we said, number needed to treat to improve patient's stroke scale is about 8.6 in this situation. So we've really pushed to pushing that boundary, pushing the envelope, and going out even further.
Right.
Across the board, people are looking at large vessel occlusion, and I think this has now become standard of care. The future of ischemic stroke, I think, is not only expanding those targets like we talked about, but also multidisciplinary care. So always working to improve that door to puncture time, that diagnosis time, and finding ways to improve and expand the indications for treatment. The potential here is dramatic. There are trials looking at injecting stem cells into area that had infarction. There are trials looking at if we can just give a neuroprotectant while you're in the ambulance on the way to the hospital to help save the amount of energy that the brain is using so that the damage to the brain goes down during that period when it's not getting blood. And also looking at TNK versus TPA and the new medications that are out there. A lot of that research is still being done, and I think that's going to expand what we can do in the future here. The other thing is looking at patients who have strokes that look pretty significant even on their first image. We started opening up those vessels to look at whether or not we can impact their long-term outcome, whether or not they need surgery, and whether or not they can still have salvageable brain. So this trial in Tesla just got closed recently, so we're hoping for the data to come out of that very soon. And then, of course, patients wake up in the morning and are weak. So we have trials called Extend IA and Wake Up, both looking at whether or not these patients, even if they have areas that are salvageable in CTA, looking at their long-term prognostication on MRI. So there's a lot of clinical trials, and you can see there's about 300 current clinical trials at clinicaltrials.gov looking at stroke and stroke thrombectomy and long-term outcomes. So there's a lot of work being done here to look at motor function and activity for these acute stroke patients. The next thing is multidisciplinary care. And I think the biggest jump in care for these patients is happening in the rehab sector, improving that post-stroke recovery. And this is something that not even us as the acute practitioners or surgeons see, but I think it's part of understanding the holistic care for these patients. And this is just one example, but we've started doing a lot of rehab that gets the patients involved, gets them involved even when they're at home. And the dramatic increase that patients have in their mobility and their quality of life just by having extra rehab sessions or actually being able to go to them dramatically changes their life. So we've moved from early identification to extending our targets and to really, finding that final standpoint where we can impact them even in their home and impact them in that rehab process. So there's a lot going on. And I think all of this plays a role in understanding where EMS specifically plays a role. But understanding that there's so many different moving parts, I think definitely helps people understand that there's a lot they can do to impact each step, particularly in that early first 24 hours.
Right, definitely. And and I'm really excited. Like I had no idea about a lot of these trials and studies going on. So I can promise the system from the Office of the Medical Director that we will definitely be keeping our eye out. And when these are, coming available, we will definitely be integrating those as we can. But no, it's absolutely fascinating information, and I truly appreciate you taking time out of your busy day. I can see you're still at the hospital, so you got to be getting ready to go home. But thank you so much, and I'm really excited, and can't wait to get this out. And I think the men and women will really enjoy this.
Andrew, thanks for having me. Appreciate it.
Yes, sir. Well, thank you again, and from Pinellas County EMS, we thank you, and hope you have a great night.
You too.
Thanks.